Okay, good morning, doctors. Welcome to this morning's webinar. A powerful soft tissue imaging algorithm, so easy, even a caveman can do it. I'm very excited to be delivering this morning. I'm just getting my controls in. If you would, I just need to know that you can hear me. So in the questions box, if you would just type in, yes, I can hear you. Anybody out there, just go ahead in the questions box, just text, yes, I can hear you just fine, so that I know that I'm coming across loud and clear. Great. Thank you very much, doctors, for letting me know that. Okay, we're going to get started this morning. I am so excited to be delivering this one this morning. It's a little different. If you've seen this before, it's a little bit different than what I have done before. And I think you're really going to like this. Okay. I am with Spinal Kinetics. I'm the Director of Education for Spinal Kinetics. I'm also the CEO of American Spinal Injury and Impairment Consultants. My name is Dr. Kronk, in case those of you that don't know me or those of you that are new on this program this morning. We do at least 2 programs a month on various topics. And this one I'm going to talk about our imaging algorithm. And I'm going to start by actually explaining that's with Spinal Kinetics, we're actually revitalizing chiropractic science. That's what we're revitalizing, and we're doing it with our science-based injury assessment technology, which will become apparent as this program moves forward. We're making science-based spinal instability or spinal subluxation assessments an actual standard. Now, I know that may sound kind of interesting, but that's something that no profession has actually accomplished. And we're accomplishing it now daily in Spinal Kinetics with our providers. So we're kind of a leader in the role of doing that. We've become that. I feel very, very fortunate as a doctor of chiropractic and also as a doctor who has a law degree. I feel very fortunate to be with Spinal Kinetics because it allows me to organize an area of information in such a way that providers can now standardize their workups, and that feels really, really good to be part of that. I know that we have an incredible staff at Spinal Kinetics that's very, just super incredible if you've ever interfaced with us, with the doctors. I mean, just an incredible staff, and we're fortunate to have that. So before I start today, what I want to do is I want to actually, I made a statement that said, hey, look, Spinal Kinetics is revitalizing chiropractic science. Well, let's make sure everybody understands what science is, because I think today, there's a lot of misunderstanding of very simple terms. Science is any body of knowledge which is accumulated and organized to solve problems. That's what a science is. It's a body of knowledge that's accumulated in a specific subject, and it's organized to solve problems. Now, this one's going to be really kind of important to understand, especially if you are a doctor of chiropractic. Philosophy is the underlying reason why you organize the body of knowledge in the first place. So you have something that you're trying to solve, and you say, hey, the way to solve this, we need to organize this body of knowledge. That's called philosophy. The rationale or the reason why you organize the body of knowledge in the first place is called philosophy. It's nothing else. That's what philosophy is. Now, philosophy is inherent in all sciences. Every science is a philosophy. Now, the reason why I point this out is because in my profession, the profession of chiropractic, most of the providers and most of the experts and most of the educators that I come across in the field today don't actually know those basic definitions. And so you've had a split where you've said, we have this split of chiropractic professionals that say, well, I'm philosophically based, and another group says, hey, I'm not philosophically based, I'm scientifically based. Nothing could be scarier than to listen to these. Philosophy is inherent in science. You can't have a science without philosophy, and you can't have philosophy without a science. All sciences are philosophies. Every single science that's on this planet currently, if you go back 200, 300, 1,200, 2,000 years ago, It was the philosophy of astronomy. It was the philosophy of metallurgy. It was the philosophy of organization. It was all sciences, so astronomical sciences, engineering sciences, organizational sciences. 200 years ago, 400 years ago, 800 years ago were called philosophies, not sciences. Today they're called sciences. There is no difference. You can't have one without the other. So what is a science? Organized body of knowledge, organized to solve problems. What's a philosophy? The reason why you organize in the first place. Now, what's technology then? Anything that makes the science easier to apply. Now, there is a science called the Science of Chiropractic. It was an organized body of knowledge, and it's an ever-growing body of knowledge that has been sorely underappreciated and sorely understood within the profession of chiropractic. There is the science here of chiropractic, and there are tools that make it very easy to make that science applicable standardly. And that's what we're going to talk about today, because that's what Spinal Kinetics has done. We've created a powerful, when we say we, when I say we've created, I created a very powerful spinal soft tissue imaging algorithm. I created it in 2004. And I created it in 2004 when I realized that providers did not understand how to standardly assess spinal trauma. Now, it since has becoming broadly understood that this is not only for spinal trauma, since trauma is the main initiating event to the disease called chronic pain. If you understand trauma imaging, you also understand chronic condition imaging or condition imaging, because they're really the same. So what we're going to talk about next is we're going to talk about, we created this basic imaging algorithm based on chiropractic science. We're a medical company, and we took chiropractic science. Now, one of the things we have to talk about is all sciences, every single science is free to create new terms or to describe or define what the terms mean in their science. Stem cell science, or we took regenerative medical science. You're going to see terms in there that are unique to that science. If we take medical science, you're going to see terms that are unique to medical science. If we take engineering science, you're going to see terms that are unique to engineering science, and that science defines what that term means. Right? So we're talking about an imaging algorithm, and we're saying that we took it right out of the science of chiropractic. Now, it's applicable to doctors of chiropractic, doctors of any medical specialty, anybody that deals with the spine and wants to understand and be able to accurately diagnose what is causing the spinal condition is going to use this science. So in chiropractic science, chiropractic best practices, it says introduction to general radiography. Now, what is radiography? Well, radiography is a technology that makes it easier to utilize the science of chiropractic. Now, I'm going to go out on a limb here and be pretty bold here in just a second. All right? In radiography, in the best practices of the chiropractic profession, this is what radiography was for. It was to make an assessment of the spinal subluxation, make a determination of the spinal health, including the presence of any soft tissue injury, the presence of any fractures, and the presence of any bony pathologies. It was to make an assessment of any spinal instabilities, and it was to make an assessment of any disc or degenerative changes, and make an accurate count of the vertebra and levels for individual patient. Now, that sounds simple, but I'm going to tell you, in 98% of the chiropractic practices today, it is not being practiced. Now, it's also not being practiced in a lot of medical practices. Spinal Kinetics, as a medical company, is bringing it to medical practices to standardize their own medical practice. So what kind of medical practice would this pertain to? Orthopedic practice, surgical practices, pain management practices in the medical space. Right? Now, it should be also done in every chiropractic office in America, right? Standardly. All right, let's make sure we understand the terms. Remember, all sciences get to create terms. So one of the things that when you lose a science, so if some of you are thinking out there today who are doctors of chiropractic, hey, it doesn't seem like our science is really as intact as it used to be, or maybe I didn't even realize we have a science. Well, if you want to knock out a profession's science, how you knock it out is you knock out the terms. So I just defined for you this morning science, philosophy, and technology in a way you probably will never forget it. Science, body of knowledge organized to solve problems. Philosophy, the reason why you organized it in the first place. Technology, anything that makes it easier for that science to utilize to solve problems. That's it. It's all you need to know about it. So let's make sure that we understand some key terms. Spinal subluxation. I traveled for years, and I teach a lot of programs on ligament injuries to doctors of chiropractic. I can stand in a room of chiropractors, of 100 chiropractors, 200, 1,000, and say, what is a spinal subluxation, and get a whole mixture of what it is and what it isn't, and I'll even get half the room that says, closes their arms and say, I don't believe in a spinal subluxation. Well, nobody has to believe in a spinal subluxation. A spinal subluxation, as defined in chiropractic science, is a misalignment of the vertebra that causes interference to the nerve, which then displays a clinical symptom. That's what it is. Now, and it's a misalignment of the spine, right? So here we have a misalignment of the spine. If this causes nerve interference and it causes a symptom, let's say there's pain going down the arms because of a nerve pressure here. Let's say there's headaches because of a nerve pressure here. Let's say that there's a neck pain because of a nerve pressure here. Let's say that there is vertigo because of nerve pressure here. Let's say there's visual disturbances because of a nerve pressure here. Then it's called a spinal subluxation. Now, if I remove the clinical condition, let's say I remove the pain going down the arms, or I remove the headache, or I remove the neck pain, the patient no longer has it. The spinal subluxation has been removed. Now, the misalignment may or may not be removed, but the spinal subluxation has been removed. Now, I'm going to tell you that it's always better to realign the spine, and as a practitioner who did that, but the definition of a spinal subluxation is a misalignment of the vertebra or a misaligned movement pattern of the vertebra that causes a clinical symptom. Remove the clinical symptom, you've removed the spinal subluxation. Now, let's talk about spinal instability. A spinal instability is any vertebral body, any motion unit that has excessive motion that causes a nerve interference to it is called a spinal instability. Now, if I remove the clinical condition, I've removed the spinal instability and then left with just excessive motion. Excessive motion into itself is not necessarily a problem. It's only a problem if it causes a clinical symptom to arise. So these two terms here are 100% identical. 100%. And I believe that's why the framers of this guideline and the doctors that framed this guideline were some of the sharpest providers in the world today, because they set up an imaging algorithm that the whole world will use. Now, it says here that I have to be able to determine the presence of any soft tissue injury. Well, soft tissue injuries such as ligament injuries cause excessive motion. And the more excessive motion I have, the more injury I have indicated. So it's very, very simple. I have to be able to do a motion test in order to determine the soft tissue condition of the spine. Now, I also need to look for any fractures, which X-ray can find, or bony pathologies, such as degenerative disc disease. I need to make an assessment of any disc or other degenerative changes. All right, again, I need to be able to, how much degenerative changes is there? What's my soft tissue condition? Is there a spinal subluxation, and is there a spinal instability? They're one and the same. Now, here's where I'm going to jump out on a limb, doctors. How much? I want you to just type in right now in the question box, and you'll get used to my style. I want you to type in my question box whether that was the most succinct explanation that you've ever seen on the science of chiropractic or of science in these terms in general. So just tell me if you like that. Yes. Yes, very much so. Oh my gosh. Yes. Amazing. Right on. Okay, good. And I appreciate that because when you're in a webinar, I can't see you, right? So when I'm live, I can actually see you and I can see the effect that my communication is having on you. So, and I want you to really get this. So I appreciate you just communicating when I ask, just communicate through the question box so that I can get a feel that you're tracking with this. So now let me explain something to you. Now, this for many of you or some of you may cause you some concern. But I am going to be, as an expert in this field, not wishy-washy. It is not possible to do this right here. It's not possible to make an assessment for spinal subluxation, determine the presence of any soft tissue condition, the presence of any fractures, the presence of any bony pathologies, or make an assessment for any spinal instabilities without X-ray. It is not possible to do that. Doctors that are taking patients in and just using general manipulation without really this type of an examination procedure cannot do this. Now, this is really important when it gets into injury care because injury care is the condition that causes both acute and chronic conditions. But I just want to be very, very clear in what I'm saying here because, again, we are, as part of the thing that we're doing with spinal kinetics is we are revitalizing chiropractic science. And we're taking it out to other professions and we're putting that science in their hands as well because they're also dealing with spinal injury patients and chronic pain patients. So what I'm saying here is this cannot be done without radiology. It's not possible. Anybody that's teaching today that it can be is false. And anybody that thinks it can be, it's very easy to actually show it's not possible. Okay, now that's not to say that people can't adjust the spine without x-rays. You can adjust the spine without x-rays. You just can't determine the information that's right here on this slide. Now, let's take a case example. Patient comes in, because I want to show you this algorithm. Let's say a patient comes in with migraine headaches, right? Now, some of these images are going to be different. A person's going to look different. I just want you to understand the symptom. Patient comes in with migraine headaches. She also gets some ear pain, some facial pain at times. At times, she gets numbness, tingling, and a sense of weakness or heaviness in the arms, right? Would this be an unusual scenario? So type in to the question box if you think this would be kind of a good scenario or a normal scenario, something that's very common in your offices today. Would this be common in your offices today? Yes or no? Normal, absolutely. Normal, totally. We see this all the time. Okay, good. So we're not dealing with anything that's abnormal. All right, so let me go back real quick. What's she in for? She's in for migraine headaches, but she also gets some ear pain, facial pain. She may get some neck pain. She gets some numbness and tingling or going down the arms. And I apologize, this is a guy's picture in here, right? Now, let's talk a little bit just about the migraine, right? It's an extraordinary condition, and it's extraordinarily prevalent. Neurological disease affecting 38 million men, women, and children in the U.S. alone, 1 billion worldwide. Now, some of you are looking for new patients. All right, let's talk a little more about it. Migraine is the third most prevalent illness in the world. Nearly 1 in 4 households includes someone with migraine headache. Okay, now 1 in 4 households is a lot of households. And I'm going to tell you, the households that have a chronic migraine headache sufferer spend 70% more in medical services every year. That's a lot of money, doctors. A lot of money, right? Attacks are often accompanied by one or more of the following disabling symptoms: visual disturbances, nausea, vomiting, dizziness, extreme sensitivity to sound, light, touch, smell, tingling, and numbness in the extremities or face. Okay, what did we say they have? Gosh, we said that they have migraine headaches, ear pain, facial pain, and tingling going down the arms. Okay, totally consistent with a migraine headache patient, right? So everyone needs to know somebody or suffers with this themselves, right? Now, here you're doing the workup. At age 22, she's 36 now. She's 35 now. At age 22, she was in an auto accident, treated with a DC for, I don't know, 5 months. Had neck pain and headaches, but no migraines at that time, right? Feels that the care was pretty good at that time. You know, doesn't really recall anything negative about it. Doesn't really recall much about it, except for she had to go in a bunch of times, and you know, people seem nice, right? Now, she doesn't have any recollection of what condition she had or what was injured in her neck, nothing. Now, since that time, you know, 27, 28, 29 years old, she started to get these migraine headaches. And they started to get worse and worse and worse and worse. Now, this did not have to be this way for this patient. What this patient needed in both the auto and what she needs now is identical. She needs a doctor that understands her condition, right? So we go in now, we've taken this history, 22 years old, she had auto accidents, these were her symptoms, this is what she did. Now we go in, we say, okay, great, Mary Smith, Dr. Kronk, April 27th, 14 years ago, she had this accident. Now I'm doing an exam, right? And on the exam form, I'm actually going, wow, okay, if I do a motor test of everything, and I didn't put all this in, this is in a PowerPoint, these little boxes are hard to fill in. So if there's nothing here, just consider it was all negative within normal limits, right? But we went to motor testing, and her upper cervical spine tested weak. And so did her C7 nerve test weak. Right now, we did some sensory testing, and when we did some sensory testing at C2 with light touch and pinprick, she actually couldn't feel this area. Right? And then when we did some light touch and pinprick in the C3 area, it was what? Well, it was altered. In this case, it would be hyper or hypo. You could actually list it in this box. Right? So when we do sensory testing, we want to know, is it altered? Is it normal? What is it? Right? So we know that we have these two areas are problematic, potentially. Now, what's the one thing we don't know, though? We don't know what they look like inside. We don't know what this patient looks like, right? So we can't do a spinal instability examination. We can't do a spinal subluxation conclusion. We can't determine the level of severity of soft tissue injury if there is any. We don't know if there's any fractures there. We don't know if there's any degenerative change in the spine. And if all of that information is not known, to me, the patient is really in a deficient office, right? Because it's too important. This information is too important for the life of the patient. Now, let's take it a step further. We send out the x-rays, and we find out that we have severe ligament damage that's ratable at C6, and we get back our report, and we also find that in our upper cervical spine, we have severe offsets in the let me see if I thought I had that. Yeah, okay, so We sent out our stress x-rays, which included A to P open mouth, lateral bends, and we now actually report, and again, if these are left blank, just consider they're normal. On the x-ray, we saw that we had a reverse cervical curve. We're not going to get that. You already know that. You know that when you took it. And is that abnormal? Yes. Can that cause problems? Yes. But where in this abnormal reverse cervical curve is the initiating cause of probably the reversal of the curve, and where are these subluxations? Where are the spinal instabilities? Where is the active condition that's now causing the patient's condition? Well, lo and behold, look at this, C1. Wow. And what does C1 affect? It affects the C1 nerve and also the C2 nerve. Now, that is, oh, I'm sorry. Well, actually, it would have, yes, it would affect the C1 and the C2 nerve. Now, if we actually look over here and we go, okay, we have severe C6. Well, where does the C7 nerve go out? It goes out through C6 and C7. And on C6, tested on C7, we have a severe translation finding. Doctors, I've just clinically correlated the condition. I've done a subluxation assessment. I can tell you this patient has severe subluxation. I've done a spinal instability assessment. I can tell you this patient has severe spinal instability. I've done a soft tissue assessment. I can tell you that this patient has severe soft tissue trauma indicated through both imaging and examination procedures. I can tell you that there were some other things found, and I can also tell you that I didn't note any degenerative change in this 35-year-old spine. And I can do this in minutes. Absolute minutes. Does not take long at all. Now, again, just looking at the upper cervical, okay, we know that these are the symptoms of an upper cervical ligament injury. We also know that pain, numbness, and tingling going down the arms is also one of those symptoms. So I got complete correlation with exactly what the patient has, and now I can apply science-based treatment procedures. Now, this webinar this morning is not designed to teach you science-based treatment procedures. You're experts, you're doctors, you already know that. Right? This was just to teach you an algorithm, an imaging algorithm. So easy a caveman could find it, could do it. Because I expect, or we expect, most doctors to understand what their adjustments are doing with the type 1, type 2, and type 3 mechanoreceptors. Right? Because it's completely based on science. Now, here's the thing. The reason why you want to be on these programs when we deliver them is a really simple statement. The best investment you can make is an investment in yourself. The more you learn, the more you earn. Okay, what I just showed you this morning is a multi-million-dollar practice. All right? Now, what I just showed you this morning, 98% of the providers in the world today are not doing. But that doesn't have to be you, right? That doesn't have to be you at all. Over 65 million healthcare visits were made for musculoskeletal injuries. A lot of you want to be in injury work. Well, you have to do these workups in injury work, right? So patient comes in, you got to do the consult, you have to do the neurological testing to the level, then you also have to do the imaging, right? And it's very simple. This is an imaging algorithm that I produced in 2005. Actually, I was using it way before that. I just formally wrote it up in like 2005. I think we did this one in 2011. It's probably why the image doesn't look that good. Anybody who is involved with spinal kinetics has this right in the back office. Right, and it just explains, it just says, hey, look, what's an abnormal finding? Well, less than 1 millimeter is normal. Greater than 1 millimeter, but less than 3.5 is abnormal. greater than 3.5 is severe, right? So it just tells you this. And this imaging algorithm now is being used to allow doctors to actually successfully treat, not only treat and identify and diagnose the real condition that the patient has, but also be able to manage that patient so that one, it is preferably gone at the end of any kind of corrective care, and then two, has the ability to maintain and support that patient so that the condition is not continually arising, right? That's true today for chronic conditions, and it's also true today for injury. It's specifically, it is extremely problematic for a patient to be involved with a doctor that does not understand the simplicities of what I just showed this morning. And I think that's pretty apparent for you all this morning. Now, we create Spinal Kinetics is a imaging company. That's all it is. It's an imaging company that does spinal excessive motion testing. I believe we're the top imaging testing company in the country. We support lots of chiropractic doctors throughout the country. We support medical doctors. We support osteopaths. We support anybody that's involved in spinal treatment today. AMSIC, American Spinal Injury Impairment Consultants, is my own company, and that's the top educational company on this particular topic, right? So a lot of times doctors have questions. Hey, look, I'm brand new. How do I get involved with Spinal Kinetics? You go to thespinalkinetics.com and you put in a new doctor request. You'll see there's a box. You just put in information into it and we'll call you. For those of you that want more information and education on how do I understand this better and how do I market it, because it is an absolute virtual gold mine in the market right now. It can't get any easier to build. And I don't care if you've been in practice for 20 years, 30 years. I mean, if I could show you some of the emails that I get from providers that are 20 years, 30 years in practice, going, wow, this answers more questions to anything that I've ever done before. So for those of you that are interested in a simple training program and an injury marketing program, it's smartinjuryeducation.com. Now, I'm going to open it up to question and answers. So you can actually either ask me questions in the question box, or if you have a mic and you're brave, you can go ahead and raise your hand and I'll unmic you, or I'll unmute you. All right, and you don't have to be brave to do that. I was just kidding. Okay, so here's oh, I like this one. You talk about being scientific, and yet we use a term that most of the world has already defined differently. If we say that chiropractically the moon is really made of cheese, doesn't it make it right we are defining it within our science? Without the tight muscles of the body compensate for the injury, there's nothing to stop the bones from moving or being in any position. Only the tight muscles hold the bones out of position, which is really stuck within the normal range, or more precisely, a segmental dysfunction. Only when it gets out of normal range of motion can we accurately call it a subluxation. Yeah, that's totally false though. So I understand what you're saying, doctor, and this is why I'm saying what I'm saying. That's totally false. Now I realize you don't have any way to defend, and it's unfair, but there's nothing scientific to back up what you just said here. And it's also, the science of chiropractic has defined its own term. We've defined our own term. And you'll see that the academy, or all of the chiropractic colleges agree with the term that I just gave, right? So it's the most common agreed upon term. Now, it is identical to a spinal instability, another very well-defined term, right? So anybody that wants to knock out the science, and I think in chiropractic as a profession, we can see that the science has been knocked out. How you do it, how you knock out any science, is you alter and change the terms. That's actually how you do it. So if I want to destroy a science, let's say I want to destroy engineering science, I actually am going to go in and start to alter the terms in an educational process to destroy the science. Okay, great explanation I just got. Thank you, doctor. What about the patient who has trauma which causes ligament injury but has minimal pain and no neurological deficits? What about the patient who has trauma which causes ligament injury but has minimal pain and no neurological deficits? Okay, let's make that even easier. What about the patient who has had trauma which caused ligament injury but has no pain and no neurological deficits? What do you call that? Human being enjoying their life, right? That's what you want to have. That's exactly what you want to have. So I don't totally understand the question. Now, what about a patient who has trauma which causes ligament injury but has minimal pain and no neurological deficits? Perfect. That's exactly what you want to have. If possible, you want to remove all the pain. Now, let me ask you this. What about the patient that has severe misalignment that has no pain and no neurological deficits? What about that patient? It's exactly what you want. That is what the market is looking for today. See, what you have to understand is right now, and I know it's a touchy subject, but if we look at the current sciences and the application of those sciences, whether you want to acknowledge this or not, we have an epidemic, a health epidemic of chronic pain. So the experts and the current sciences and the expert use of those sciences by the experts today in the market have caused the largest epidemic of chronic pain in the history of this planet so far. So let's don't take awesomely poor results and look at that and say, wow, that has anything to do with our science or our application of the science. It has everything to do with this application of the science. It's the cause of it, right? So we have to take a look at our models today, and that's all I'm saying. Whoa, I love these questions, doctors. I really appreciate this question. How do you differentiate between a medical subluxation and a chiropractic subluxation? We can use the term subluxation, but within a much more restricted definition, only when out of normal range of motion. Okay, so let me ask you this. I wish I had a mic on. Do you have a mic here? Do you have a mic? Do you have a mic on your computer?
Can you hear me?
Yeah, I can hear you totally.
Okay.
Okay, perfect. So what is the definition of a medical subluxation?
Oh, a bone out of normal position, a partial dislocation.
Okay, what's a chiropractic subluxation?
Depends who you talk to.
No, I'm talking to you.
We use it for anything that's not in a normal static position.
Would that be a bone that's misaligned?
No, it's within its normal range of motion. It's just stuck over there. It's not moving like it should.
Okay, but that's not those aren't the definitions that the chiropractic profession got to utilize in order to get insurance inclusion in the 70s.
I understand that. Doesn't mean it's right.
Well, let me ask you this. How were the 80s for insurance? Were you around in the 80s?
Yep.
How was insurance in the 80s?
Not too bad.
How is it now?
Worse.
Or would you say worse? Give me a break, Dr. Travis. Would you worse? It's practically non-existent.
That's pretty worse.
Good. So maybe this conversation that we got into about trying to differentiate the difference between a medical subluxation and a chiropractic subluxation led to those results as well.
Well, it causes conflict with the insurance industry because they're dealing with medical subluxations at the same time from the
No,
MD
they're not.
profession.
No, they're not. No, they're not.
Nobody's using medical versus chiropractic in all their terms. They're just saying subluxation.
But I'll tell you what. That's not the experience that I have, and I do educational programs with insurers. The only place where I hear the term medical subluxation is in chiropractic.
That's because they just call it subluxation, and it's defined in the CPT manual. Partial dislocation is defined in Dorland's.
Yeah, no, I get all that. I get all that, but
because we want to change the definition doesn't mean we're right in changing the definition.
We don't have to change the definition, but the bottom line is we don't have to change the definition. We just have to understand the definition.
So only when it's out of its normal range of motion can we accurately call it a subluxation.
Good. So let's give you something to look at here once. These are good, and the reason why I want to do this is because I think it's good for doctors to hear it, and I really appreciate your participation with me right now. Let me look at something once. Let's go back. Okay, you see this one right here? See this vertebra here to the left?
Yep.
Okay. Is it abnormal in motion?
Probably.
Good.
That's not a motion study, so we can't say for sure.
No, it's. I'm going to tell you. I'm going to tell you right now. This moves back and forth 4 millimeters.
That's abnormal.
Good. So when it's moving abnormal, and you look at it right here, is it out of position?
Probably.
Is there any way for it not to be out of position?
Yeah, there is.
How?
If it's moved back within its normal range of motion.
Right, but I'm saying when it's moved out of its normal range of motion.
Right.
Is there any way for it to be aligned?
By itself or with intervention?
By itself or with intervention.
Yeah.
Good. So what you need to do is you need to teach, right? Because what you're teaching right now, what you're saying right now, nobody in the world has been able to figure out. Do you understand that?
Nobody's been able to figure out what?
Nobody has been able to figure out how to actually take an excessive motion joint and make sure it's completely aligned and stays that way.
Aligning is one thing, keeping it there's the other problem. Good.
So I think we get the point. So the biggest thing that I would say to you is that the only place that we hear this, and like I said, I want doctors to actually hear this, and I really appreciate your participation in it, is that when a subject is made complex, the subject's not fully understood. It's only when you make it simple that you come out the other side and actually you actually understand what is the issue. So anybody that takes it and is still very, very complicated to them, still very complex, that's the state of today. And that's what I'm saying. That's what we're doing. That's different. Dr. Travis, I really appreciate your participation.
Well, if you
go ahead. What did you say?
Take a neutral radiograph of that, it might appear to be within its normal range of motion, but it could be out of neutral position, and somebody could call it a subluxation, but only when you do the flexion extension and show the excessive motion can you accurately call it a subluxation. Otherwise, it's a segmental dysfunction. So you have to do the stress views.
Right. No, that's why we did the whole. That's why I did the whole program on the algorithm. Absolutely. Thank you, Dr. Travis. So basically, what all I'm saying, and I'm not saying it. I am actually saying and taking the position I'm taking because it's a position that is an axiom. An axiom in a science is a self-evident truth that really requires no proof. It's so self-evident it proves itself. And that's why this imaging algorithm itself is so important. And that's how easy this is to do. right? So let me ask one more question. Let me see. Dr. Travis, I'm going to ask you another question.
Okay.
Okay. So this stress testing that you do, you're saying that basically this is how you would do a subluxation assessment, correct?
Yes.
Okay. Do you do that with every patient that you treat?
No.
Why?
History. Most of them are restricted motion and not excessive motion.
Good. Okay. I got it. Totally got it. That's all I wanted to know. That's all I wanted to know. Okay. So I am still, and I'm not, again, I really appreciate this doctor's participation here, but it's not possible to actually do the assessment that I just showed you. It's not possible to do it without x-ray. So if you are not taking x-rays of that patient, it's deficient. And I'm going to tell you that the other thing with this is that the doctors that are doing this on a regular basis are doing this with all of their patients. Those are at the those are the ones that are actually meeting the needs of the market today and exactly what this market needs. So let's see, any other questions? Any other questions? Okay, would this work for a trauma patient? Yeah, oh my God, absolutely, absolutely trauma patient. Do you recommend A to P lateral flexion in all accident patients? Yeah, because there's no way to assess the cranial-cervical junction without it. So I wrote a report called The 3 Pitfalls with MRI and Spinal Ligament Injury Diagnosis. Anybody can get it at smartinjuryradiology.com, smartinjuryradiology.com. And in that, where I wrote is that it's X-ray and X-ray science, and it's really, again, chiropractic science, that has shown that in the cranial-cervical junction, you can't tell how much ligament damage you have unless you do the A to P open mouth lateral flex. And oh, I got you. And he's actually asking A to P lateral flex on all accident patients. Yes. The reason, again, is because you cannot determine the severity and location of a ligament injury without knowing the excessive motion. There's a thing called a biomarker today. You'll hear it in a lot of sciences. A biomarker is an individual measured condition in some body or some field that when the measured condition is there, it indicates a condition. So if you had a blood sugar problem, there's going to be a blood sugar range that says, hey, you're diabetic. That blood sugar range marker in the blood is called a biomarker for diabetes. If you had HIV, there's an HIV antibody that's a biomarker for the HIV condition itself. For spinal ligaments, the biomarker and the imaging biomarker is excessive motion. That's what's left behind if you have it. So yeah, if you're gonna, there's not an injury patient today that I wouldn't have a stress study done on, because I'd want to know where and how bad is the ligament injury itself. Above, how many millimeters of translation and ligament instability would be a contraindication for the spinal adjustment? That's a very, very good question. Here's what I'm going to tell you. I have seen them as high as 9 millimeters of translation in the C1 area. The highest levels of translation findings that I've seen we've done probably, God, I don't know, I probably reviewed, I use this figure all the time, 40,000 some x-rays. We're not getting in the dislocations. We're not getting in the instabilities that have actually caused cord damage. Okay, so the highest instabilities that we see for translation measurements are usually in the 5s. 5 millimeters of translation, we've seen those that high. We don't usually see anything in the 6s, 7s, way out of range, right? So normally you're going to see it, if you understand the range, 0 to 1 is normal, 1 to 3.5 is abnormal or a moderate sprain finding, above 3.5 is severe. you're going to see your severes going from, say, 3.5 to the top range of maybe 6, maybe. But if you got a 6, you're way up there in the range. So, you know, anything over that, then you may want to do other types of testing. You may want to rule out that you've got, you know, whether you've got a fracture or not. If you're talking about angular measurements, we've seen them as high as 25, 26 angular differences that respond very, very well to conservative care. Anything above that, now you're probably looking at something that's pretty unstable, highly unstable. How low is the range? How low in age are instability measured valid for? That's a fantastic question. So out on the Spinal Kinetics website, under articles and research, there's a research paper that was done on kids. And on kids, on small kids, the same ranges were used, the same values were used. However, what I'm going to tell you with kids is that kids are more flexible, so you're going to see usually what you're looking for in trauma in a child is, let's say that you have translation measurements that are 3, 3, 3, 3, 5.2. Okay, that 5.2 is way out of their normal range because they are going to be a little bit more flexible. However, if you read that, then you are going to, if you read that research paper, you're going to realize that the research says you apply the same numbers. If you have 1 millimeter translation inflection and 2 millimeter translation extension, do we add these to a 3 millimeter total instability? Yeah, if you're doing for determining how much excessive motion there is in the spine, yes, you would actually add those. Now, you have to make sure, and this is a little bit complicated without a visual, but you have to make sure that your 3 millimeters, let's say, is going anterior in anterior motion, and it's going posterior in posterior motion, right? So let's say I had 3 millimeters of anterior motion in flexion on C5 on C6. I had 3 mils. All right, on extension, I still had 2 mils of anterior forward motion on that same vertebra. Well, then I really only have 1 millimeter of excessive motion. So excessive motion is a back and forth motion test. That's what it is. Okay, what else do I have? Okay, what was the website again for the educational materials is smartinjuryeducation.com. If you want the MRI report, you go to smartinjuryradiology.com. And again, everything that I'm showing you doctors today, I am showing to medical providers, top orthopedists, top neurological people in the world. All right, it's not just this is a science that actually needs to be broadly in the market today, because it'll seriously reduce down the amount of chronic conditions that are in the market today. It doesn't have to be that bad. Thanks, that helps, clears this totally up. Okay, good. Thank you so much. Yeah, you're welcome, doctors. You're very welcome. So let me just scan through, see if there's any other questions. Oh, here's a good one. So I understand ligament instability and how that is supposed to increase whole body impairment. But when I'm dealing with many attorneys using spinal kinetics, they don't use the impairment to increase the settlement even after I explain the importance of any suggestions. Okay, good. So this is a great question, and I love these questions because it's really just a comment. It's not a question. It's just a comment. Okay, so my comment back is going to be this. How do you like the state of personal injury attorneys today? They're in a bad state. All right. One, they don't know the injuries that they represent, and two, they really don't know what's the important information that anyone needs to know in order to determine the value of a patient's insurance benefit. Right. So what would I do, doctor? I would take them out to the Colossus website. by the Computer Science Corporation, which they just conglomerated to a new corporation. But if you Google Computer Science Corporation Colossus, their new corporation will come up. It's kind of a bad website, but it'll come up and it'll say what Colossus reports. Now, Colossus is standard for any insurance software system now, and it'll tell you that they need that information in order to determine a claim. Now, the idea of what attorneys need and attorney education is so unbelievably simple that it's just that easy. You got to get involved with smartinjuryeducation.com and start educating the attorneys. You'll get a lot of referrals. Okay, again, this program isn't for that. This program today was just on the simple imaging algorithm. And I know that when I do question and answers, the question and answers start going all over the place. But they are so easy to deal with today. And that, you know, the biggest thing that gets you in with the attorneys, tell them how bad the other doctor's documentation is and paperwork is, and how the other doctors don't even understand the condition, they don't understand the terms or the condition or anything else. And so they make for incredibly horrible deposition doctors, let alone results. What attorneys do you recommend in Eau Claire, Wisconsin? Well, I have an office in Eau Claire, Wisconsin. I don't live in Eau Claire, Wisconsin anymore. And you would want to call me and set up a time with me, Dr. Anderson, to go over what you would do to revitalize the attorneys in your local area. There's a lot of attorneys, a lot of good attorneys in your local area, but what you'd want to do is revitalize those local attorneys. And it wouldn't be that hard to do, very easy to do. What else do we have? Okay. What do you do when somebody doesn't agree with your position? No, okay, I'm assuming, doctor, you go out and somebody doesn't agree with your position. Leaders don't crave agreement, right? If I see something, Ingus Semmelweis is a great story. Ingus Semmelweis is an Austrian physician, and he's watching all these babies die in hospitals, 25% mortality rate in hospitals. If a woman comes to the hospital and has a baby delivered there, they got a 25% chance of either losing the mom or losing the child or losing both, right? So he looks at it and says, well, what's causing this? And he looks and he says, well, the doctors come in with their smocks from the autopsy room and they deliver these babies. Maybe there's something on their hands. So he says, okay, we're going to clean them up, put them in different clothes, and make them wash in a chloride-based fluid, water. We're going to make them wash their hands. He almost drops the rate of mortality to 0. Now, do you know what happened to him? Nobody agreed with him. He lost his medical license. He was put in an insane asylum, and he died. Now, about 40 years later, 50 years later, they come up with a microscope and went, wow, Ignis was right. Okay? All you have to do is have great understanding of what it is that you're explaining or teaching. I mean, I can put the information that I just showed you. I don't care what the deposition is. I don't care who the provider is. It stands, it holds, as all truths do. So just don't be afraid. Absolutely don't be afraid. Okay, doctors. Anything else? I'm just looking through. Anything else? Let me go up real quick. Okay, I've done that with whiteboard presentations showing them the value drivers, etc. Yes, okay, doctor, I would be the first one to teach you that if you want to have no referrals, 0 referrals for a very long time, then what you would want to do is do a whiteboard presentation to attorneys showing them the value drivers of Colossus and those various things. Okay, that will get you 0 results. How would you like an attorney to come to you and teach you how to do a subluxation assessment and show you exactly how it's supposed to be done, and you're sitting there going, wow, you don't know the first thing about my profession or what I do and how I do it. Okay, it's not going to work. I understand. I did it too. I tried those things a long time ago, but it's not going to work. Wow, never thought of it that way. Yeah, think of it that way. It's not going to work. What you want to do is you want to get out to smart injury education, and you want to get involved with, one, here's the clinical product that I can deliver that makes you completely 1,000% unique, right? And I'm telling you, the biggest problem that doctors have with it is it's so simple. Even a caveman could do it. It's so simple that you think it can't be right. It can't be this simple. It's got to be more complicated. The biggest thing that doctors do when they get into the program that I developed at first is they try to overcomplicate it. There has to be more to this. No. And so when you go to attorneys, it's very easy. What you want to go to attorneys with is what does an attorney need? An attorney needs great documentation, right? Well, what do they get right now? They get documentation from doctors that get these explanations on all kinds of weird stuff. And yet when they look in the file, they just want to go, well, how injured is this person? Oh, they're tore up. They got C1 problem, 4.1 millimeter to the right, 2.3 millimeters to the left. They got migraine headaches. They got visual disturbances. They got post-traumatic concussive syndrome findings. You want to throw the mild traumatic brain in there if you want to. They have pain going down the arms, good. They got a C6 problem. God, we got a rateable ligament damage at that. We even sent out for an MRI. It confirmed the fact that we also have a disc herniation there. We treated them for 6 months. We got them real stable. Didn't completely 100% recover. There are some duties under duress that are still there. And I mean, you've got a package that they're going, oh my God, okay, how do I get that? In other words, you have to present to something that it's like if I come to you and I present something where you don't have a problem, well, what's my solution going to do for you? Right? So the biggest thing is it's so easy today to go out and start to communicate with attorneys and do it the right way, you know? All right, what else? Anything else? Good. Yes. Okay, Dr. Kronk, where do you have the program for the attorneys? That's in Smart Injury Education. That's under Spinal Injury and Impairment Consultants. That's under my training program. Why are Spinal Kinetics charges $500? Seems out of line. Out of line for what? It's not. If you understood what it takes to actually create the technology, maintain the technology, and then have radiologists actually do the procedures, and if you understood how long the procedure takes, and you also understood how long it takes not only for processing, for us to get it in, and the costs of doing it, it's not a range at all. So, and out of range compared to what? I mean, it is what it is. We have, I won't even talk about what we're doing with national providers right now, but we have some fantastic relationships with national providers and national carriers. So, and we're getting better and better with that. As you'll see in the next 6 months, we'll solidify some serious relationships and also some serious market with it. So, Doctor, I'm going to tell you in the spinal ligament area. Right now, if I went in and did an injection, or I go in because I also do some work with providers that are in the pain area. If I do an injection, that injection will take me about doctor's time. It takes about 5 minutes. That's $4,500. So, you know, that's. I hope that helps. If it doesn't help, just call me and we'll talk. I'll talk to you even more. The other thing to mention on that is when you're comparing costs, you have to compare costs with what other companies charge. So if other companies charge, let's see, I don't know, $1,000 for an MRI, and we charge $5,000 for an MRI, then you could say, yeah, those costs are out of line. So, you know, my thing would be, in compared to what? Who else out there is putting together a company that actually does what we do? So if you're going to compare, you have to compare apples to apples. And you would have no idea. Spinal Kinetics is the hardest business I've ever been involved with. It's the 1,000% the hardest business I've ever been involved with. And the biggest reason why it's so hard is as a business is because there are so many doctors that don't understand what an excessive motion test is and what it does. Do you guys ever consider putting more medical legal language into your reports, such as causation statement if we give you a clinical history of the patient? No, absolutely zero, nada, never. And the reason why we don't do that is it's not our job. It's your job. Our job is to give you an accurate assessment. Your job is to do all of that. Your job is to be the treating physician. So it's totally your job. Okay, do they charge directly to third-party insurance, the not at-fault insurance company? Yes. We charge to the at-fault insurance company, to the third-party insurance company. We take LOPs, we take liens. We're probably the easiest company in the country to work with when it comes to that. So it's just very, very easy. Plus, the other thing you want in a medical legal situation, elite radiologists do this on some of their MRI reports. Okay. It'd be interesting to see on elite radiology on some of their MRI reports. You really have to look at it, because an MRI has no focal film distance, right? These numbers all come from images that have a focal film distance. So MRI has no focal film distance, and so somebody at elite radiology would have to have a calibrated system. I helped develop these systems, would have to have a calibrated system in order to do that study. And they may have that. If they do, it's fantastic, great. You will have issues with it probably because, one, it doesn't qualify for anything in the impairment guides itself, and because it's not normally done on an MRI, because of I'm only giving you one of the factors. I can give you a lot of other factors that would cause it to be problematic on an MRI. Any attorneys you recommend in the Austin area? No, I haven't worked enough in the Austin area for me to get around to the Austin attorneys. I was just referring to medical legal language on the reports. Yeah, medical legal language. I know exactly what you're referring to. We would not do that ever as a company. Again, that is your job. We're not going to sit there and go through your document. See, we take a study in, and we have a process to process it. I mean, if you want us to do causation analysis as well, $500 is not even going to be close to covering that charge. In case you haven't noticed, medical providers command a large fee. The American Pain Association says non-specific mechanical low back pain is going to cost $9,000 to $19,000 per year to medically manage. Not correct. Medically manage. So, you know, when you get into medical is very used to charging. I was okay. Does spinal? Yeah, does Spinal Kinetics perform reads on dynamic motion X-ray, digital motion X-ray? Sure, absolutely. Digital motion X-ray is no different than a plain film X-ray. You have to freeze frame the film. One of the only problems with DMX is that you have all these images to pick from. So if we're using DMX images, and you want to send us the images that you've picked, there's a way to do that. But yeah, absolutely. All right, any other questions? And I really appreciate, the questions are where everybody learns, so I really appreciate the interaction with the questions. Absolutely. Good to know. My friend bought a DMX machine. Okay, good. Perfect. There are definitely, there's technique issues that your friend is going to need to learn to understand on digital motion X-ray. All right. Any other questions, doctors? Thank you for all of the information. Yeah, you're so welcome. You're actually welcome. Okay. That being said, I'm going to let you go. Get back to work, doctors, and thank you very much for your time. I hope it helped you in some way. Here's what I do know. The very next new patient that walks in, you're going to have in your mind exactly what I communicated on this webinar, and you're going to wonder if what I said is what's causing the patient the problem. And here's what I'm going to tell you. If you look, it is. Doctors, thank you very much.